Okay, so welcome everyone. This is the clinical session for the April 2021 business meeting. The session will run for 3 hours. I'll run through the agenda in a moment's time, but just to say that we'll allocate a comfort break in the middle, so we won't keep you in front of your keyboard for 3 hours. We'll give you a break in the middle. I'd like to welcome our presenters as part of this session. So there's Dr. Tejal Shah. She's from Newcastle University, from the School of Computing. Dr. Amelie Dendhoven, who's Professor and Consultant in Anatomic Pathology at the University of Antwerp. Sabine Ley, who's the Associate Professor in the Department of Clinical Medicine from the University of Bergen. And then last but not least is Botes Jani, who's a Senior Lecturer and Honorary Consultant from the University of Glasgow. So I'd like to welcome them and thank all of them for presenting today. Just in terms of the agenda for the next 3 hours, we'll run through two of the presentations before we have a comfort break in the middle. Then we'll have a further presentation after the break, and then myself and Jane Miller will provide some updates around Snomed International and around some of our clinical reference groups and project groups. And then Charles, in his inimitable way, will make some closing remarks. Just to let you all know, the session effectively has been run by the clinical engagement team, of which I head up the engagement team along with Dr. Charles Guttridge and Jane Miller. We have a page on Confluence, which holds everything that's vaguely related to clinical engagement. This session actually has its own agenda page over here. So if you go onto the clinical engagement portal, you'll be able to access the session, the agenda. On the agenda, we'll also post the slides from each of the sessions, along with any questions that we don't have time to answer during today's clinical session, and they'll be made available afterwards. And this is a bit of a plug, but we also have an expo in October this year. Loosely speaking, it's will be based in Lisbon, in Portugal. It'll be a virtual event. We're looking for abstracts, so particularly abstracts related to the clinical use of SNOMED. If you have anything that's you think would be interesting, please submit them. The closing date for abstracts is April the 30th. And details are on our website, which is snomed.org, about how to submit. And I'm going to stop sharing there, and then I'm going to hand over to Tejal and let Tejal introduce herself and teach us all about SNOMED education. So over to you, Tejal. Thank you.
Thanks, Ian. Hello, everyone. Very glad to be invited here and speaking to you all over here. As Ian said, I will be talking something about our experiences on training in Snomed Ct. So I'll just start with sharing my screen. Sorry, please bear with me. Can you see my screen as yet?
Not yet.
Okay, let me try again.
Ah, now we can.
But Ian, sorry, could you tell me if you're seeing the presentation?
Yes, so we're seeing the presentation. At the moment, we're seeing 2 slides though. So you're seeing, if you're using a Mac, you're seeing the presenters on the Mac rather than the main screen.
So probably.
Now we're seeing half of your screen.
I'm so sorry. Okay, let me try this again. I'm very sorry, everyone. I should actually share the screen. Okay. Let me stop sharing. Okay, I think now it should work.
Excellent.
All right, sorry everyone. So that was not a very good start when I'm going to talk about training considerations. So, and I'm going to share the problems about training online anyway. So you've already seen one of those. Well, so the idea behind this presentation that I have is sharing some experiences from the courses that we have developed and delivered on Snomed Ct. What we have understood through our experiences, through literature reviews, is that in the case of training, it's important to deconstruct Snomed Ct, to demystify Snomed Ct. It's not enough to say that it's useful. We know it's useful. We know the benefits, but how is it useful? Why is it useful? What does it do? So that's the idea behind the whole of the training that I'm going to talk about, whether that's at the introductory level or at the advanced level. These concepts are essential to really cover in case of training. But before I start, quickly about me, I used to be a dentist, and then I moved into doing Master of Health Informatics. While as a dentist, I had no idea about terminology, Snomed Ct. I got to know about these things, these concepts, semantic interoperability, and all of these advanced concepts when I started doing my course on health informatics. In fact, I also could I had the opportunity to actually work with Snomed Ct at that time. This was way back in 2010. So there was no standardization at that point, and I was in Australia. So all of this was happening in Australia. But I did get the opportunity to work on Snomed Ct on projects and in hospitals where they were still trialing that. Having said that, I couldn't understand all the details about Snomed Ct. That is, what is the theory that underpins Snomed Ct. And hence, when I started doing my PhD, that was the time I really could go into the nitty-gritties, the depth of Snomed Ct. And I had fun learning about that, because I learned that through some very simple concepts like a pizza. So in order to learn something very complex like Snomed Ct, we can go and look at something that we all relate to. So something as simple as a pizza. How is a pizza constructed? How would you compute that kind of knowledge? We all know that as human beings, but how would you put that knowledge about how do you construct a pizza onto a computer? So that's where the technical jargon comes in, and that's how you understand and correlate something that you know in the real world, a domain expertise, as you would all understand over here, but the technical elements are related to something that is so understandable, that is something very simple. So I really got to understand about Snomed Ct, building on simple principles of constructing a pizza. Also, the language that underpins Snomed Ct, that is OWL, or Web Ontology language. And then you must be wondering, why am I saying all this to you? The reason is I have continued with those elements of learning into the courses that I teach now. So I try to explain the complex using something very simple, something that people understand and relate to. And hence, as an academic continuing my work, that's what I have been doing. I'll exemplify that using the course that we designed. But before moving into the details about the Snomed Ct course in particular, I'll just talk about the whole program. So this was the Health Informatics CPD program that we designed at Newcastle University. We did that in collaboration with Health Education England Northeast. This was mainly to address some of the digital skills gaps in the region, but also to provide the training that is required for flexible portfolio trainees. So the flexible portfolio training is a scheme that is offered by Health Education England and Royal College of Physicians in the UK. And over there, as part of that scheme, the fellows of the portfolio trainee, they have one protected day during the week when they can undertake some kind of training, advanced training that is non-clinical. So in this case, in the northeast of England, they had the pathway of clinical informatics. So essentially, the flexible portfolio trainees, they were learning about clinical informatics. And hence, we started offering this program. There was no formal training before this. So we wanted to do something to help support them. The idea was ultimately that we provide this program as an introductory program, open to clinicians as well as non-clinical practitioners, everyone. So basically, we cover the base concepts, the important concepts in health informatics, that someone who is beginning in health informatics or who at least has some experience in health informatics but wants to learn about the theory behind all the different topics. That's what we plan to cover in this program. So this program consists of 10 courses. Each course is about 3 hours of learning time each. In 2019 and 2020, this program was delivered as a face-to-face delivery. So we had almost all the participants who were quite local, that is within the northeast of England. And in the last year, since lockdown, we had to do it online. The advantage was that it removed the geographical barriers. So participants from across the country could actually join. And we saw a lot of participation from beyond the region. We also wanted to keep these sessions as small group settings. For one, this was a program that we had just started, so we were not sure how. We still wanted to learn while delivering it. We wanted to understand what we will need to do better. We also wanted to use the learner's own experience, their own knowledge to help promote discussions. So kind of an active learning environment where learners learn amongst themselves. The reason is because almost all the participants on the CPD program are working clinical practitioners or non-clinical practitioners, and they bring with them a ton of experience. So we wanted to utilize that, and that's quite possible in small group settings rather than in a classroom kind of a setting. Lastly, as a CPD, it's important to accredit them. Obviously, it benefits the learners, but it's also useful for us as the educational providers because it ensures that our course is of high quality. We get the feedback from the experts. We can review that. We know that the course remains relevant. So accreditation is quite useful for both the educational providers as well as the learners. So what did the participant profile look like? Now, this is just for the Snomed Ct course. Across both the years, we had 34 participants on the course. And everyone was a working professional. So as you can see, they were all adult learners. And our hypothesis that we would really get people working in the domain to join this program was corroborated. But unsurprisingly, most of the participants did come from the clinical background. However, interestingly, we did have non-clinical participants as well. So I think it was an important thing that we decided that we make the program quite introductory in nature. So we don't talk from the perspective of a particular system or a particular electronic patient record, but we provide the theoretical underpinnings to all these important health informatics topics. The interesting bit here is that on the program, there were 10 courses and participants could join one or more or all 10. Most of the participants generally joined for all 10 or more than one. Only 4 participants were exclusive to Snomed Ct. Now, this might have some relevance. That is, what about Snomed Ct training if we were to offer that in a standalone format? Would it be useful or relevant? And why didn't we have more people joining for Snomed Ct in particular? It could be that Snomed Ct standalone courses might be more beneficial and useful to advanced practitioners, or it could be that because these are at the very beginning stage in their careers as clinical informaticians, they might really, as of now, not know much about Snomed Ct. So they might not know that this is the kind of training that they would like to undertake. So offering this as part of the whole program, I think, was a good idea because it does expose the learners to Snomed Ct, which probably they wouldn't have if not for this course. So the development and delivery, how did we actually plan that? You all must know, at least in the UK, there is no standardized curriculum in clinical informatics or health informatics. So we had to start from scratch. Of course, we looked at the literature, we reviewed the literature. We looked at the core competencies, not just from within the UK, but internationally. We saw what they were suggesting, what the learners must learn. We also considered the pedagogical principles. That is, as I already said, that we're going to have adult professional learners. So we want to utilize their experience. We want them to be discussing. We want them to be active learners here. So we just don't want to have a very instructional kind of an approach. We want to be facilitators, more of. And lastly, of course, collaboration. This was one of the key elements. Health informatics or clinical informatics is not, it's not a single discipline. It's actually a multidisciplinary area. So you have IT, you have computing science, you have healthcare, many different areas. So obviously we didn't want the perspective of just one person working on this. So we worked with academics, we worked with clinical practitioners who really know what's there in the world, what are the challenges, what are the problems out there, even if they are not working exclusively in clinical informatics. We also worked with experts in informatics domain. They can be clinical practitioners as well. It's not mutually exclusive. So it was really useful to get these perspectives to understand what are the real challenges, whether our program, the courses, and the examples that we produce, would that be relevant? Would that be useful? A key element in the collaboration was our learners. So while this was a bespoke CPD, we knew who the learners would be, at least in the first round. It was the flexible portfolio trainees. The program was also open to external participants beyond the flexible portfolio trainees. So we didn't know who would join from that particular cohort, but we had access to the flexible portfolio trainees and we worked with them. We listened to them. We asked them about their expectations to make sure that their expectations are met or they know exactly what this program is going to offer. We wanted to corroborate as well our hypothesis that we want to keep it at a very introductory level. We want to explain the theoretical underpinnings rather than just focusing on the use of technologies. And working with the learners did really give us the confidence that, yeah, we are on the right track. So it was quite important. If you as education providers have access to the learners, it's a key element to development, I would say. So with respect to Snomed Ct, we looked at literature and we wanted two answers from the literature. One was, why Snomed Ct? Why should clinical practitioners learn about Snomed Ct? And what should clinical practitioners learn about Snomed Ct? We'll go to that in a bit. Focusing on why should clinical practitioners learn about Snomed Ct and what the literature says, Snomed International itself, the website itself, in its 5-step briefing page, says about the benefits of using Snomed Ct. And I think for this group, I don't need to specify the benefits. However, for learners, this is what they read. This is what they see in the literature, that Snomed Ct is great. It's useful. It's also the standard in England. So all healthcare providers must be using Snomed Ct. We are not there as yet. General practitioners systems, yes, but not necessarily in secondary care. However, it's going in that direction. So ultimately, all clinical practitioners will need to be aware about Snomed Ct. So yes, this is something else that they read about, that we need to understand what Snomed Ct is. And interestingly, this was also the first reason identified in a survey that was carried out way back in 2011, but it's quite relevant today as well. In that survey, Tim Benson and Ed Conley, they asked the learners, what do the learners need to know? What do you think you need to know? And the first reason that they gave in terms of why would they need to learn Snomed Ct was actually this, that it's a standard. Curiously, we didn't find literature that would say that the learners wanted to learn because how it can be used to improve, healthcare, what they can do with it, how can it improve their practice? Perhaps because at that point of time, they might not know about it, or basically it's not probably clear in the literature. And there's very little literature in explaining what the learners really want. There's quite a bit in what kind of curriculum there should be about adoption of Snomed Ct, but not much in terms of the learning requirements. So this survey is actually, it's a minefield of information in itself. So that was what we learned from literature. The second bit about what in Snomed Ct. So what is the literature saying? What are the academic publications? What are the competency frameworks? What are they suggesting? What should you teach to learners in case of Snomed Ct? This is a sample, a snapshot from International Medical Informatics Association on education in biomedical and health informatics. I have just picked that bit that refers to terminologies and ontologies. So as you can see here, it does say that learners should be learning about terminologies and ontologies. They also very usefully actually categorize learners into two categories, as an IT user or as a specialist. So an IT user would be a clinical practitioner who would just be an end user and might not be involved in more of the development or on the back end side of things. But a specialist would not just be the user, but would be involved in development work, implementation work on the IT side. So this particular recommendation by EMEA does highlight who needs to know at what level. If you see, the plus sign refers to basic and the plus refers to a higher level, probably intermediate. However, it's not clear what is basic, if you may, or what is intermediate. What is the plus? What would include? Snomed is massive, as you know. So how do you distinguish this thing? The other thing that we also looked in the competencies is not just exclusive referral to terminologies, but also other elements that the frameworks mention. For example, here, learners should also know about informatics, computer science terminology, and the domains within that is basic informatics terminology, knowledge. They should also be aware about decision support. Now, all of these things, the underpinning technologies, again, terminologies, ontologies. So even if not exclusively mentioned, you see there are multiple times the reference is made to the importance of learning about terminologies. In our case, our learners, we knew that they are the ones who are actually interested in clinical informatics. So we do not classify them as IT users. They would, even if not now, they want to proceed and probably become specialists in this field. So we are looking more at the BMHI specialist level in this case. The next was, we also looked at the flexible portfolio training curriculum that's designed by the Royal College of Physicians and Health Education England. It also says very clearly the importance of covering terminologies, nomenclatures, decision support. But again, it's very difficult to identify what should be covered, how do we cover, at what level. Going further into these literature, there's some more information. And as you say, what's highlighted here in EMEA, they mentioned that BMHI specialists must know about machine processing of data, information, and knowledge. They must be aware about semantic interoperability, ontology-based software engineering. Similarly, in the paper by Ed Conley and Tim Penson, they also mentioned that all health informatics professionals should learn about description logic, which forms the basis of the way that Snomed Ct concepts are defined. Well, this does give some more advanced information and knowledge to basically that we need to talk about terminologies, but yet it's not entirely clear. So we also looked at barriers to the adoption of Snomed Ct. It's important to look at barriers when you're designing a course because often it relates to education and training. So we wanted to see if providing certain level of education or training would help learners, guide them towards learning further about Snomed Ct, motivate them, make them curious, and eventually these barriers could be addressed. So again, in the survey by Tim Benson and Ed Conley, they do ask the participants on what they think are the barriers in Snomed Ct. A few of the answers I've listed here, and I don't think these answers would surprise anyone today as well. So you see the survey is quite relevant even today. These are probably the barriers that exist in the workplace today as well. Snomed Ct is considered inherently complex. It is complex, difficult to find the right code. Post-coordination adds another layer of complexity. So these things do highlight the term of complexity. It's the theme that's running around in terms of understanding Snomed Ct. So how can education and training help? As I said, if we don't need to not talk about the technical details, which I've often found in my conversations that clinical practitioners don't need to know about technical details. Well, in a way that's correct, because if you're not going to be implementing things or working with the technology directly, fine. But I think clinical practitioners who want to be clinical informaticians, they must have a good overview picture of what technology does, what it's capable of doing. And hence the idea of education should be that we talk about this technology, we explain this technology in a way that it's understandable, in a way that it gives the learners an overview of what that technology is. It doesn't make them an expert in working with the technology, but it does give them a good grounding into what this technology can do. So when they go back into their organizations, they know they can make informed decisions about implementation, development, and contribute, in that case, with their IT teams. The other thing that was highlighted as a barrier was the documentation is long and complex. It's quite right. In a way, I have myself, I'm self-taught in Snomed Ct. I have almost read all the documents available on Snomed International website, on NHS digital website. So it's excellent. All the documentation is excellent. But someone who's starting out, who's new, who may not have the technical, theoretical underpinning of this, it's good to start, but often it really is difficult for them to understand how to proceed, where to end. And this is what I've learned from my conversations as well, that many people do start reading about things, but then they don't know what to do next. They don't know what is enough for them. What should they be learning? So I think the idea of our training was that we also signpost to these documentations, get them motivated intrinsically. They develop their own wish to study this, and then direct them to the right kind of documentation from these resources that's available from Snomed International and NHS Digital. So that was the idea in our training. And as you see from the picture here, it's obviously about a lift. It's a guide to the lifts, London underground train station. And if you just look at it, it seems quite complex, but if you look at it carefully, if you look at one thing at a time, you can easily understand everything. So I think that's the principle that needs to be adopted when we teach about Snomed Ct as well, that you break it down, you break down the complexity into simple elements and then build it up to understand the whole complexity of Snomed. So it shouldn't look so problematic or scary. So for example, when we looked at all of these things, what the literature was saying, what it was saying that you should teach about Snomed description logic. Learners should know about that, but then how do we do it? So we simplified. I'll give a couple of examples here. Like, how do you represent natural language? It is something that you do. It is something that underpins Snomed Ct. So for example, this is an expression in Snomed Ct. Just looking at this, for someone who has no idea about Snomed Ct or who has never had any start, it can be, it wouldn't make any sense, but it's actually quite simple. However, when the literature says you should teach about description logic, it's not suggesting that you talk about OWL functional syntax or how it's represented in the description logic notation itself. Explain what this actually means. So this whole sentence in Snomed Ct, it can be represented through natural language quite easily. What it reads is, any disease with associated morphology of inflammation and consolidation and with finding site as lung structure is equivalent to or a type of pneumonia. So basically, this is a representation of natural language in a computable form. And that's what Snomed Ct does. It picks our knowledge, it picks the domain knowledge and represents it in a way so that computer understands. And I think talking like this with the learners has really helped. So it makes them feel that, okay, it's possible to understand Snomed Ct quite easily. It's not so problematic that we simply have to avoid the technical elements about it. Another example, and this has always brought up a lot of conversation, is logical deduction, which we do in our day-to-day life. So for example, if you are told that Jane Doe lives in Sydney, it's a fact, it's a factual data that you have. And if you were to ask this kind of a question, which Australian state does Jane Doe live in? You have been told nothing else about Jane Doe, only that she lives in Sydney. But you have a knowledge base, that's your brain. You know certain things coming from your own experience. You know that Sydney is a city in New South Wales, it's a state in Australia. So in this case, when you know this, you combine the background knowledge that you have with the data that you get, and that's how you answer questions that do not have explicit answers in the database anywhere. So in this case, Jane Doe lives in Sydney is the only thing we knew, but based on the background knowledge that we have, we can answer this question as Jane Doe lives in New South Wales. Similarly, within the knowledge base itself, you can make such kind of deductions. So for example, we can ask, which country is the city of Sydney in? Sydney is in Australia. So this is how inferences work. This is how subsumption works. This is the logical deduction that Snomed Ct performs. And starting from a simple thing that helps them understand what logical deduction is, really helps them understand how Snomed Ct works, what the inferences in Snomed Ct look like. The next thing we looked at was the UK Faculty of Clinical Informatics core competencies. So we looked at the literature, we identified areas that we need to cover, but we also wanted to make sure that we help the learners achieve certain defined competencies. And the UK Faculty of Clinical Informatics has a core competency framework, which has 111 competencies. And these are the snapshot of competencies that refer to terminologies or Snomed Ct and are important for anyone learning about Snomed Ct. So if you see the main headings, these areas are interoperability and integration, how Snomed Ct is important in case of interoperability, how it's important in case of knowledge management or any kind of computational model, any kind of computable form. It's important for knowledge management. Similarly, for data analysis, for improving data quality. So we wanted to understand these competencies and then draw the learning outcomes using these competencies as well to make sure that we cover these areas within the course. So back to the why, what, and the how. To summarize basically our approach, the why. We saw in literature, what is the why? Yeah, Snomed Ct is good, it's useful. But what we wanted to do is in the 3 hours we had, we couldn't cover everything there is about Snomed Ct, and we wouldn't even aim to do it. So how do we best utilize these 3 hours? There's good literature out there. We want to point that to them. So in these 3 hours, we decided that we show them the possibilities of Snomed Ct. We introduce the basic concepts, but make them active learners, make them participants in this, get them to be motivated, inspired, that they might want to learn more, give them the information to proceed in a certain direction, that are they looking eventually to work to do data analysis. In fact, we had such conversations as well when someone wanted to eventually run some kind of analytics, which they said is currently not possible in the current system. So how you can do that in Snomed Ct. So basically, these are the kind of conversations we wanted to have. These are the kind of things that we wanted our learners to take away from. And eventually, they should be able to contribute to the digital developments in their organizations. Essentially, we wanted to tell them what is possible so that they can ask for things when it comes to systems, implementations, electronic patient records, the user interface of Snomed Ct on various systems. Unless you know what to ask for, unless you know what is possible with Snomed Ct, you cannot effectively make those improvements. So that was our idea, to give them an overview of Snomed Ct and explain to them that why Snomed Ct is really as good as it says it is. So in terms of what, these are the topics that we covered. Obviously, these are very general over here right now. As I said, we broke down the complexity. We covered the complexity through simple elements and tried to explain what exactly Snomed Ct does, how does it work through such kind of examples. We did cover some of the advanced topics. If you see here, queries and expressions are not necessarily considered as introductory. But as I said, we did not cover the topic of queries and expressions in a way that we expect the learners to take it away and become expert query writers. It was mainly to show them how things work within Snomed Ct. All of these were mainly used for educational purposes, but at the same time, give them the understanding of what an expression is. So all of these topics were with the aim that we want the learners to understand what's happening under the hood, if you may. We also used the browser. In this case, we wanted to show what the browser is, how learners can search using the browser. And we used both NHS Digital and the Snomed International browsers because there are some differences to that. So basically, we wanted them to come out of the user interface that they might have seen, the limitations that there are, and to see Snomed Ct in its entirety. And I think the browser remains a very good source of that. So how did we do that? As I said, we had a collaborative approach to development. We did all of these developments through interdisciplinary working. So for example, in both the years of our courses, I worked with Denise Downs. She is an encyclopedia of knowledge and experience. She's now retired, but she worked at NHS Digital as the implementation and education lead. So bringing my technical knowledge into this and her experience, her understanding of how Snomed Ct works on the ground together, this is how we developed the course material and utilized that for delivery. We adopted a learner-centered approach. As I said, we wanted participants to be discussing. We wanted them to bring their experiences in. However, it's important to understand that although all the learners in our course, they are adult professional learners and have a lot of experience in terms of Snomed Ct, almost they didn't. I mean, no one did. So we didn't want to rely on experience in that end. This is the time when we swapped from facilitation to instruction. We made sure that there's a fine mix of these kind of approaches so that the learner is not left to their own device in terms of learning about Snomed Ct. And as I already said, we distinguish the technical for understanding and for doing. What we adopted in this course was that we explain the technical enough so that they understand. It won't mean that they will be able to work with it. And lastly, we used browser. So what did our learners say? So this was, again, all of this, as you know, was built on hypothesis, talking to people through interactions with the experts and adopting this approach. We wanted to see whether it worked. And when we asked, what did you find the most useful? These are a sample of the feedback that we received across both the years. If you see, there are similar themes. So here what you see is that the learner has said that they were skeptical that Snomed was going to be as useful as it was. But this course was insightful, and that is what our aim was. We wanted them to get an insight into Snomed Ct, to explain why Snomed Ct is good, why it can do the things that it can do, and it can really do the things that it says it can. So that was the idea. And again, the second comment as well corroborates that knowing about the possibilities and what we must learn was useful. These two are again on the same theme, that demonstrations, use of the browser, explaining through examples was actually very helpful and helped them understand. Again, describing things graphically, more visually, was also what we aim to do. And this is what this comment does say, that the slides describing Snomed Ct structure and concepts are very effective. So we tried to move the static into more of an animated kind of a version and explain step by step that how things work within Snomed Ct, how subsumption works, how attribute relationships work, how they are connected together. This last comment is quite interesting. If you see, this learner was just not aware of Snomed Ct at all. Now, this is not surprising because this particular learner came from a non-clinical background. And in my interactions with many from the non-clinical background, they have said this, that they were never aware about Snomed Ct. But this is quite useful to know. So it means that our approach of using an introductory approach to really talk about the basics of Snomed Ct rather than from a clinical or a non-clinical perspective was useful. It brings in more learners. It gives people who otherwise would not have gone on to learn about Snomed Ct an opportunity to learn about Snomed Ct. And similarly, for the other courses that I've delivered, also I've had similar feedback. One of the courses was with Charles Gutteridge himself, who's the CCI of Pots Health, and it was organized on a similar theme, that I talked about the technical elements, and he presented a very interesting demo of a sandbox application from Snomed International. So this was also quite well received. And if you see, look at the comments, it helped them better understand the potential for Snomed Ct. And Snomed Ct, they would be able to use Snomed Ct more effectively. So I think these are the kind of comments that do confirm our choice of approach, and we plan to continue with that. But sharing it here as well, that if you are interested in doing educational courses, I think you could adopt a similar approach as well. We also asked the learners what would they like to learn more about. And we wanted to see, have we raised some kind of an inspiration in them? Have we motivated them to learn more about Snomed Ct? That was the idea behind this question. And the comments that you see here actually do answer that question, that they wanted to learn more about Snomed Ct, how it makes Snomed really clever. So when I was talking about logical deduction, I was talking about how we as humans use the logical deductions in our day-to-day lives, how we become clever, if you may. So that is what Snomed classifiers do. So this comment relates to that how can we really improve the potential of Snomed Ct by incorporating the various elements that really bring out the full potential of Snomed. This comment talks about real-life examples of how questions can exploit the ontology. So what other kind of questions can you ask in the real world? We used simulated data, we used hypothetical scenarios. So we wanted to, in this case, see what real-life questions can be used. We were also asked what to do if the code does not exist. Now, we really didn't anticipate this question because it was supposed to be an introductory course for beginners, and we didn't think that people might be involved in working with Snomed Ct at a level that they might be wanting to add additional codes. However, it's a lesson learned. So from the next iteration, we actually did include this information as well on who to go to, where to find further information if they have any questions and things like that. Again, real world examples are very useful. And this was another comment, that more clinical and real world examples to corroborate. I think this is something that we want to continue adding. And the idea that we want to start with the technical and move to the clinical was that now that they are able to get some deeper understanding of things when they see them actually in the clinical workplace. So this is a comment that really helps in understanding from that perspective. And lastly, when it comes to Snomed Ct and when it comes to coding, it is quite important to explain the difference between Snomed Ct and the classifications ICD. So we had clinical coding professionals on the course, so it was quite important to help explain that. However, these particular comments mean that once we introduce Snomed Ct at a basic level in this way, we need to then refine the audience, separate them out, and see what their professional roles are, and then touch upon the elements of Snomed Ct that are relevant to each of these learners. So finally, the concluding remarks is that we are aiming in our training program to completely demystify Snomed Ct as much as possible, to get the learners themselves motivated, curious to learn more about Snomed Ct. So it's important when we try to adopt this approach to know our learners. Are they users? Are they specialists? Obviously, our approach may not be feasible for others in case of undergraduate curriculum, for example, or someone who just wants to understand Snomed Ct so that they can just use it without going into any details. We have to consider the pedagogy when we design any course. As I said, we did want to consider the adult learning principles. We wanted to also facilitate the courses rather than instructing. However, this is a comment from the paper by Tim Benson and Ed Conley, where one of the participants did say Snomed Ct is not intuitively obvious. It needs to be taught. And that's what we have tried to do. The technical elements we try to teach, and the rest we try to bring that together through experience. Formative delivery is quite important. We adopted the online one. We were forced to in a way as part of lockdown. We had a synchronous and asynchronous mix where learners are expected to do some kind of learning by themselves at their own pace in the asynchronous time. And then the synchronous setting was mainly for question answers, summing up the content that was covered in the asynchronous format. And also some interactions and discussions, the opportunity for that. And lastly, all the development in clinical informatics should be interdisciplinary so that we can bring in different perspectives and experiences from different experts. About the content, as I already mentioned, content should be well informed by literature, by experts, by learners themselves. And it's also important to make the content simple enough. So I'm not saying that the complex should be kept simple, but what I'm saying is the complex should be explained in a simple way. And the browser should be used as an educational tool while you are explaining the concepts. I think that also worked quite well in our approach. However, we had challenges and limitations. Obviously, starting with no standardized curriculum, no experience to fall back on. We had to go through literature everywhere and figure out our own approach. The real world infrastructure does lag behind theory. So when we do say that with Snomed this is possible, we often promptly get some kind of comments that, but it's not possible now, or it doesn't happen. I've not seen it happening. It's not there in my trust. It's quite true. So again, all of these are right now based on hypothetical scenarios we can explain using simulations. There are examples on Snomed International site, which we point to some real world examples. However, often clinical practitioners, they want to put relevance to their own practice. So unless infrastructure also catches up with the theory, which has been around for years, well researched. So I think it's that limitation will stay. We also had a small sample of learners. So obviously we cannot draw generalized conclusions from what they said. And lastly, the format of delivery limitations. So although we did offer this course online, we had certain limitations. There was the missed networking opportunity. More discussions happen when learners get familiar with each other. And in this case, it is difficult. All the coffee breaks are behind the screen, shut off your videos and shut off your audio. But instead, in a face-to-face session, you are all talking, chatting, and that really helps. So that was a limiting factor in terms of online learning. And But the advantage was that it broke down geographical barriers. So many learners from across the country could access. So we have a long way to go from here. We have to continue reviewing the content. We have to continue working with the experts. We are also right now working on how to integrate this health informatics curriculum for the undergraduate students at Newcastle University. So again, it's going to be a whole different approach from the pedagogy to the content. We also want to do a Snomed Ct user and education survey. So this is quite important because looking at how people work, what they do, what their barriers are, what their challenges are, can give us a better insight into what can we teach them, what can we offer in terms of our training. Often learners cannot say by themselves that they want to learn this, especially in a topic like for a topic like Snomed Ct, where they might not be aware themselves. So rather than asking them, what do you want to learn? We want to see what they do in practice and how that can be improved through training. Obviously, before we go, we have to keep celebrating as well. And I recommend if you are education providers here, you plan on that. These are very challenging topics, very challenging experiences. So keep celebrating. This picture here is actually bottle of kawa that was left by my colleagues on my work desk when this course first launched. It was the first one in Northeast England, so it was quite a big deal for us, and it was an experience as well to see whether this is something that really people are interested in learning about, and we did learn that. Some references here, and thank you. Any questions?
Tejal, it's Charles here, just in case you're wondering whose voice it is. First of all, thank you so much for a really interesting and inspiring talk. Really good to hear your experience from the start to the finish. There are some questions that are coming from the audience. And actually, I think the first one is one that I've often thought about, which is, were any of the people that joined your course medical or nursing undergraduates, particularly medical students? And is there any part of your program related to training undergraduate at the undergraduate level?
So to answer your first part of the question, no, we didn't have any undergraduate learners on the course. And currently, we are actually reviewing the content to see its relevance to the undergraduate program. So as of now, I would say no. But can you repeat the second part of your sentence? Because I think I dropped out at that point. So I'm not sure I answered your question.
No, I think you've answered it perfectly, okay, which is really, have any medical students joined in, learnt about this? Is there, and I guess looking forward, do you see that as an area that you are going to build into? And I think you're saying yes, but I think everybody would be interested to hear, one, what you do and the approach that you take. One of the things I'd like to hear is how you ever persuade a medical school curriculum development group to allow you to get in to teach SNOMED, because I've not succeeded in that personally.
Interesting, Charles, because that's what I said. I think that was an observation that we plugged in Snomed Ct as part of the bigger, wider health informatics program. So it remains to be seen if we can actually do it as a standalone program in itself, or did it work because it was part of an overall health informatics program. However, I think it's important to acknowledge the stakeholders like Health Education England who come in, who also speak with, the powers that be at the university to explain how it is important and things like that. So I think working with stakeholders, working with influencers in the region is quite useful.
There are a few more questions. So it looks as though South Asia is joining you, first of all, and they all think you're fantastic, Tejal. And there are particular comments on how lovely your room is and how sunny it is. So I'm just giving you feedback on how inspired people have been by your talk. But the particular question is the course still running? And when's the next intake? And how possible is it for people to join just the Snomed Ct module that you have in place?
So to answer your first question, no, it is completed for this year. It is open for the current participants because we did it online, so they have time to review, but we are not taking any new registrations at this point. We plan to restart this program again in October. It is again in discussion. Every year we have to restart the process of getting approvals from the university. So we have an email mailing list that keeps you updated when the program dates are announced at the Institute of Coding. I'm happy to send that across later on, Charles, if that helps, so that people are aware on when the program will start next. But it will start somewhere around October or November this year again.
Fantastic.
The third bit was how easy it is to join just the Snomed Ct course. Although this program has 10 courses, anyone can join just one course. It's quite easy. You just register for that course. There's no questions or no prerequisites or anything at all. So we just joined the one course.
I'm going to put one in based on my own knowledge. I know a little bit about Newcastle, and obviously I'm aware that the Freeman Hospital and the other associated hospitals have deployed Cerner Millennium in the hospital, and the terminology built into Millennium is Snomed Ct. It's a particular deployment. But have you had participants from the hospital system in Newcastle joining the course? And what did they make of the course materials if they did?
So we didn't have anyone from Newcastle itself. We had some from Gateshead, interestingly, QE. So I'm not aware of anyone from Newcastle. In fact, we had actually, I'm very sorry, some of the flexible portfolio trainees who work at Newcastle, and some of the comments based on what I know who they commented. For Snomed Ct itself, we got almost all positive comments. So I would assume that they really liked the content. I don't know exact number of people from Newcastle because all the people registered on flexible portfolio trainees, they also keep rotating. So I'm not sure at what point they were at Newcastle.
Yeah,
but we did get some very positive feedback from them.
There's a question about whether the course is part of a wider sort of curriculum, and do you take applicants from other countries?
So it's not part of any wider curriculum. It's offered as a standalone CPD program. We did get inquiries this year as well from people outside the UK, and as such, we try to keep it to small group settings, as I said. So there is no limit on who can join, but it's quite useful to know that a lot of the examples and the real world examples drawn are from the UK system. So as long as it's applicable to them, then they're very welcome to join.
And I suppose there's a sort of hidden question in there, which may not be explicit in the way it's written, but is there a fee? Do you charge people?
Yes. Sorry, we have to. But we do also learn, we do also offer time to time taster programs, especially we have done in the last year. So I had a taster session on, we call it taster session, but it's a full 1 hour session on basics of description logic for Snomed Ct. So it was one step ahead of this basic program. I talked about the details of the defined relationships, primitives, and fully defined, and what's necessary and sufficient conditions, and all of these things. So again, if you would like to join the newsletter, then you could be made aware of when these sessions run. We don't have a set timetable on when they would run.
And the newsletter will advertise the courses and the dates and times
yes,
and so on.
Yes.
Okay. There is another interesting question, actually, which is, I think probably comes from Spain, but I'm not sure about that. But anyway, the question is about a team that are working for a vendor and a supplier of laboratory information systems with obviously a health IT focus. And the question is, do you think laboratory IT systems, one question is, should they implement Snomed? And the second question is, do you think the kind of course you're supplying would be useful for people developing software for lab systems?
Well, to be honest, I don't know. I think it would depend on whether they actually implement Snomed Ct for lab systems directly, and whether they consider that as an option to do that. Then of course it would be. But if not, then at least they still work with health data. So when you work with health data, you're going to bound to come across Snomed Ct in some way or the other. So if you want your, let's say the laboratory system does not have Snomed, but you would probably want some level of interoperability. So in that case, maybe understanding about Snomed Ct may be useful.
Okay, well, I'm going to add one question to that, because I think this is germane to globally, actually, but is certainly relevant to the UK. Many hospitals and collaborations are now developing biobanks where data is kept, samples are kept, and information about the source and so on, as well as images. And what role do you think learning about the use of Snomed Ct to curate a biobank, do you think that might be an area of course content that would be valuable?
I think it would be. So I'm going to bring in a learner experience at this point. So we had a learner who worked on these projects on managing health data, not necessarily biobank, but health data. And they did say that eventually it looks like they would also need to understand a lot about Snomed Ct if they were to continue working with health data. And I think that would be applicable for biobank as well. Obviously, there are other considerations, like there would be genome ontology and others, not necessarily Snomed Ct that they would interact with, but the fundamental principles remain the same. We teach about Snomed Ct, we teach about ontologies, we teach about description logic, which is again the underpinning theory for genome ontology as well. So in a way, understanding the technical elements over here are useful. Having said this, when it comes to biobanks or when it comes to research health data, it is quite essential to make sure that the data that you're going to work with is actually going to be coded in Snomed Ct. And if it is, then you need to understand all the details about description logic, because you're going to be running hypotheses on this data. So you would want to know what Snomed Ct is able to do, what your data can do, what kind of insights can you obtain from your data. And if you know how the data are coded, then it could be quite useful.
That's fantastic, Tejal. Very, very clear answers, wonderful presentation, and I think everybody's cheering you on and wanting to join your courses in Newcastle. So thank you once more for joining us. And we've run out of time, and I'm sure I've exhausted you with lots and lots of questions. And so thank you once again, and hope to see you soon.
Thank you for having me, Charles. Thank you very much.
Okay, so thank you, Tejal. And we're going to hand over the controls to Amelie and Sabine. And I'll let you introduce yourselves and just explain how you're going to present between the two of you, I guess. So over to the two of you.
Yeah, hello. Thank you for the possibility to present our project here at Snomed Ct. It's a pleasure to be here. We are presenting together, so we are running this presentation, we both, Amelie and myself. It's about our project, kidney biopsy codes for pathologists. What we are giving you in this presentation is first some key points about our professionality. Then we are talking about kidney biopsy registries and how they code, about the purpose of our project, why we are doing this. And then the core of the presentation will be about the system we developed, also the principles, the design. And at the end, then where are we just now? What are we planning for? So this is in short the content. I will start to introduce myself. I am a nepropathologist working in Norway since 1997. I'm also the registry pathologist of the Norwegian renal registry. And the last years, much of my interest was connected to e-health. So I was engaged in projects with digital pathology, structured reporting, and coding. So now I give over to Emily.
Yes, thank you, Sabine. I'm Amelie den Doven. I'm also a nephropathologist working in Belgium at Ghent, but also at Antwerp. And for me, holds true the same as for Sabine, that I'm involved in a registry of kidney biopsies in the Flemish region of Belgium. So my research interest is in this, but also broader in nephropathology topics. Next slide, I think. So I want to give you some essentials about our field, because you are not experts, I guess, in kidney diseases. Some of you might be, but I will just outline our niche and our field. So what happens when you have some difficulties with your kidneys? Sometimes the nephrologist can solve this, of course, with the clinical and laboratory values and know what to do. But sometimes he or she cannot do that and then needs to look at the tissue. So that is done by taking a small piece of renal tissue with a needle. Usually it's so it's really a small procedure. And this small piece of tissue then get subjected to a lot of different imaging modalities, let's say. So this tissue is brought to the pathology lab where it's processed for conventional histology with paraffin slides that you see on the top. Immunohistochemistry, specialized stains there are done. But a part of the tissue can also be worked up for electron microscopy. This is really a sort of super resolution microscopy where you can really look into the ultrastructure of the tissue. So this gives a lot of different images and a lot of different slides to integrate for the nephropathologist. And some facts, really our specialty is rare, let's say. There is in Europe around 1 nephropathologist per 2 million people. And the nephropathologist has a lot of work with these biopsies because, on average, 2 to 4 hours of work is spent on looking at all the stains and integrating the information and making the report. So this is also because we're dealing with complex, rare diseases here, sometimes of unclear etiology. We have to adapt classifications, prognostic schemes, extracting all of the information outside of the tissue, and this is gives a lot of work. It is though important work because according to literature, around 30 to 50% of apparently clinical diagnosis pre-biopsy change after biopsy. So this really makes a difference for the nephrologist. However, treatment schemes are still most based on experience than on really randomized controlled trials. So how does the nepropathologist do this? What is the nepropathologist actually looking at? You see the kidney to the left. The kidney filters the blood and does this with a sort of specialized sieve. This is the glomerulus. And then in the sieve, the blood is filtered, and then the ultrafiltrate gets processed in the tubulus and the interstitium. So you can have disease processing attacking the glomeruli, but also attacking the tubulointerstitial. And then under the microscope, you can see a pattern, like in the lower right, you see inflammation in and around the tubules. And then the disease that is attached to this pattern comes out also out of the clinical information about the correlation between the two. And here was a medication-induced allergic nephritis. So we puzzle together the pattern and then the disease. And all this information, all the information from the different slides, from the correlation with the clinics, then gets documented in the kidney biopsy report. And as you see, this can be rather lengthy with a lot of description. You see the macroscopy, the light microscopy, the description, and next slide. Also, immune studies get a description and electron microscopy, and finally you come to a conclusion or a diagnosis from this tissue, let's say. So the report does have a certain structure, but mostly gets filled out in free text still around the world. Next slide. And I hand over the words.
Yeah, I take over. Because of this rarity of these kidney diseases, people have to collect data, yeah, and therefore kidney biopsy registries have been established all over the world for research purposes. And we were wondering how these registries are finding their cases. And this is the question, how do registries code? So here's an overview over the 16 kidney biopsy registries we found. Most of the registries are in Europe and in Asia. And there are two characteristics about these registries I think are interesting. The one is these are usually nationwide registries, and the other one is or many of the registries are quite old. So this means two things. They have a lot of valuable data, of course, but they also might have outdated coding systems. And this is also what a couple of registries told us when we asked them for problems. So what we did, we asked the registries to code a usual kidney biopsy just to understand the coding systems and the coding practice of the registries. And this is what you see in the center is a diagnostic conclusion of one of the most usual kidney biopsies in IgA nephropathy. And then you see the coding practice of the registries. And blue means they are using a national or international coding system. And green means they are using a proprietary coding system they have made by themselves. And you see a lot of green, as so many registries use a proprietary coding system. You can also display this in a different way. You see here in the center the codes that they have been using, a lot of green codes again, and taking in consideration that this is the most common renal, one of the most common renal diseases. It's interesting how much variability is in this coding they are used for this disease. So actually, when seeing this, it's clear there is a need for an international coding system that meets the needs of these kidney biopsy registries in order to utilize the potential of these registries. And then it's like this, the registries code based on the pathology report, as you have seen what Emily demonstrated. And you have this diagnosis field, and they are to put in the diagnosis, and many pathology departments are actually coding also. But what we need is an international terminology, which also the registries can use for their coding systems. So, and this is the reason why we were conducting this project. This is the purpose of the project. We want to develop a terminology with corresponding codes applicable to every non-neoplastic kidney biopsy, which can be used by nephropathologists, nephropathology units, and kidney biopsy registries. So the project, I want to show you just shortly how we organized it, the work packages. This is the organizational chart, the central project team, it's Amelie and me. We do have a steering group, which is supported by the European Society of Pathology. There is an advisory group of expert nephropathologists and nephrologists, a lot of stakeholders, especially kidney biopsy registries. And there is also a stakeholder group, which is localized to the Renal Pathology Society. So it's not directly connected to the project, but Emily is chairing this group. There is a connection to the project, but it's not an internal part of the project. And then we have these 5 work packages, and we have engagement of both pathologists, nephrologists, and IT coding experts. To the steering group, Kerstin and Helmut, they are nephropathologists, and both are co-chair and chair of the nephropathology working group of the European Society of Pathology. Ronald is maybe in the audience, and many of you will know him. He has a background in medical informatics, and he is engaged in projects related to healthcare data standardization. And then Loreto, he's a nephrologist and researcher, and is involved in the Italian kidney biopsy registry. So now to the core of the presentation.
Yes, so after we investigated the status of registries and what do they currently use for coding the kidney biopsies, we looked at what do we want actually as nephropathologists and as registries. So what should a future better system, so you will, what should it be able to do, and what are important principles for that? And for this, we sat together with a group of nephropathologists, but also with Han Petermans, who is an IT expert and also already knows a lot about Snomed Ct. And then we came up with a set of principles in the next slide for a future system. And these principles were that we should be able to code along several axes. So it should be possible for a pathologist to not only code the disease, but also the pattern he or she sees under the microscope. This is important because sometimes you see a pattern and it's not clear what disease is behind. And then it's only through correlation, sometimes through time, that the real etiology is found. So you should have something for these patterns in order not to lose information as it's an unknown disease or an unknown glomerulonephritis. Then it's also important, of course, that some governance is established, because we are doing this project now, but what happens in 10 years or 15 years? So there should be some follow-up. The system should also be freely accessible, and we should have some mapping to existing coding systems where possible. Then it was also honored that there should be a possibility to code on paper for maybe some users or some countries, although probably digital coding will be most used and will be most easy. So this is a bit quick going through these principles. So with this in mind, we sat together, we went back to the bench to draw some system. Of course, we were aware of the terminologies around and what was used. So we knew that Snomed Ct, of course, is an international terminology with a lot of potential for use. ICD-11 we investigated, but that was for us very clinical and very limited. We looked at European ERA EDTA codes, which is very commonly used by nephrologists, but is not really made for pathology. And then we also had a look into some disease ontologies like the Orphanet and the human phenotype ontology. And at that time point, we thought, yeah, there is no real instant system, let's say, that will match all our needs. So we decided to make something ourselves. And mainly Sabine and myself started with this. The advantage is that we're both domain knowledge experts. We have experience in nephropathology, so we know what we need, let's say. And we also assembled some documents that could help us from co-workers, which are the systems that registries now use for coding, but also pathology reports from ourselves and a lot of colleagues to see what is actually, what can we base our system on. So to do this, we worked with Excel as a main tool, a sort of structured Excel list where we gathered all our terms for our desired system. And we also made a mind map of these terms. So you see that it became a complex mind map, and for you this might be maybe primitive tools to work with, but for us, not used on doing this worked very well in the beginning. Nevertheless, at a certain point, we realized that a sort of simple hierarchy would not suffice. So, for instance, certain concepts like the genetic podocytopathy is there in the middle. You cannot, like, let's say, classify according to podocytopathy or classify under genetic disease of the glomerulus, because it's both. So this is where we realized that we really need a polyhierarchic system, and there our tools did not really suffice anymore. So it got a bit complicated. Nevertheless, based on what we have drawn, or our term list, we will show you how this works in practice. You remember maybe from the principles that pathologists want to code along several axes, so want to code different aspects, that is. So because of we look under the microscope, we want to have a code for histology, like a sort of sum up of the histology light microscopy pattern that you can see in the tissue. We want to summarize the immune studies and also the electron microscopy studies. And because these different, this is from different imaging modalities, you need different patterns for that. But in the end, we want to come with data that the nephrologist can process, of course. So we also have a disease that we think the pattern fits with. So, for instance, again, focusing on this common glomerulonephritis, so you will, so an IgA nephropathy. So what can you see under the microscope? You can see mesangial hypercellularity. That is here. That it leads us too far to explain this, but you can also see segmental sclerosis. That is some sort of scarring of these glomeruli. You can see immune complex deposition of IgA, hence the name IgA nephropathy, and you can also identify these complexes under electron microscopy. So from this information and from the clinics, we know this is an IgA nephropathy, and we can code these different aspects now also in our term list. At one of the principles was that for certain users, it might be good not to have it as a too difficult system. So some people want to have a simple system, others want to have a more detailed system. So that is why we try to fold it into each other. Like you can use some compact codes, but then under the compact codes you can find more detailed, more granular codes. So you will there. So and this gives in the current version of our term list in total 511 terms, of which 142 are compact ones. This is let's say the backbone of the system, and then 369 detailed terms for people who want a really granular coding system. Still, with these terms, we cannot cover everything you might want to code. So this is why we decided to make a separate system of attributes. These are additional concepts that outside these two main pattern of injury and disease axes that you can, like, let's say, attach to the coding. So they are, however, always related to the disease concept of the pattern of injury, but can add some additional information, an additional layer, let's say, to these concepts. And examples are codes for diagnostic certainty. So is this IgA nephropathy you coded, are you sure of that, or is it just probable, or you think it is an IgA nephropathy? So you can add that information. For some diseases, you might want to add some genetic investigations. Is this really covered? Is there some genetic background there? Do we know that it hasn't been investigated? And we can also tag special cases. Maybe, of course, you want to look up things in your registry or your database. So you want to retrieve these cases based on maybe it's a teaching case or so. Okay, so this is then again a figure of the structure on how it actually looks and it works. One thing I have not told you yet, we also organized the concepts according to the compartment in the kidney that it's relevant to. So concepts for glomerulonephritis are tagged that it's glomerular concepts. We have also tubular concepts, vascular concepts, some concepts relating to different compartments, and some concepts like these certainty codes or still other, like when it's not when you have no diagnosis, this is a none. So this is actually how the system is built. And this is a sum up. We have codes organized along two axes, and these axes are pattern of injury and disease. The system has a polyhierarchy with child-parent relations. Concepts are related to compartments, belong to a compact or a more detailed list. There are concepts for attributes, and we also plan to include synonyms, though this is not completed. And of course, not Sabine, it's not something that Sabine and myself did on our own. We have a lot of people helping us out, a lot of collaborators. with the initial draft, we organized a workshop in 2019 where we collected input from different people, and the people that were actually there in the workshop are in this picture, and we fine-tuned then also based on their inputs, and came to the current version of the code list, like we have it now at the end of work package 3. And at that point, we realized, maybe this Snomed Ct is not too bad after all. We can maybe use this terminology as background for our system. This is ongoing knowledge, of course. At first we thought, yeah, we missed too much. It's not for something plug and play. But while we were building the term list, we learned. And then because of that, and this is in the next slide, from the current list, we took a subset and we tried if we could map our terms to Snomed Ct terms. And again, you see this pattern of injury terms and this disease concept terms. If you now look at the disease concept terms, then from the 105 subset, it's not from the whole list, but from the subset, we saw that 59 already have a Snomed alternative, of which 46 have a renal Snomed alternative, and some have a general, so also applying to different organ systems, let's say. So this is already something, let's say. And however, for the pattern of injury terms, this was less. For histology, it was pretty okay. There we could map some terms, but for immune studies and electron microscopy, we saw many holes. Actually, we saw a lot of holes in the Snomed Ct. In the current international Snomed Ct system. So, but there is really something already present, and this is good, we think. Yeah, so this might give a basis for collaboration. So this is where we now are in the project. So we looked at, in the first as-is stage, we looked at the current systems, then we made principles, and then we spent a long time making a term list. And now we're going into an international review process, because this term list that we have now already included feedback from project members and from different people, but we want to have more information. We want to reach the pathologists back in Canada, back in Asia, back everywhere, and let them give their inputs as well. So this is something we want to do, a broad international review process. But also we want to align with international partners, with other systems if possible. And that is, I think, while we are here as well. And in the end, of course, the system needs to have some governance. I give back to Sabine.
Yeah, this was the point. Yeah, also to think about how to do this review process and how to establish a sustainable governance. And we faced some problems. For the first, Emily has shown you our tools. Yeah, we don't have very well functional tools to represent the complexity of the term list, to visualize the system. It's difficult to handle a review process, so we don't have a tool for this either. And of course, the maintenance, how to have this sustainable governance of this term list. So what we also are missing is manpower. It's not necessarily pathologists or nephrologists, but terminology experts and IT persons. So we have 1 or 2 or 3 sometimes, but definitely not enough. And what we haven't mentioned yet, we have conducted this project without any funding so far, but it's difficult to see how we can run a review process without any funding. So we are at this point. What we have done then, we have looked at Snomed Ct. We did this mapping exercise. We saw that there are many similarities between what we designed and what Snomed Ct has. And the next step was, and what we also have been seeing in Norway and also in Belgium, they are working with Snomed Ct. They are trying to map our established coding systems with Snomed Ct. So there's a general movement towards Snovercity. So what we did next, we contacted the national release centers and presented our project, and we hope to be able to establish a collaboration with Snomed Ct. What we are doing now currently, as we are making a use case for Snomed Ct, we want to collect letters of support, and and we want to work together with this national release center. So the idea is in the project plan to put in this work with Snomed Ct just now before starting the review and the governance process. Just shortly in the end of the presentation, two maybe use cases. First is the Norwegian situation. In the pathology departments, pathologists are coding all diagnoses, but this is mandatory, but they are using an so-called NURPAT coding system, and this is based on Snomed 2, an old Snomed 2 version. Then there is this renal registry, which is using a proprietary coding system and the ERA EDTA codes. And we want now to implement the KBC codes in the registry to have a really suitable coding system. And it would be easy if the KBC codes become a subset of Snomed Ct, then we would have the interoperability to all our system and towards international collaboration. So this is one possible use case. The other one will Amelie introduce.
Yes, and this is actually something that now one of our collaborators has been implementing. So there was need in Erlangen for a database for registration of kidney biopsies, for research and quality control mainly, and they could not use their IT system for reporting for that purpose because it did not suit the needs. They wanted really a quick and user-friendly add-on database that can really register their biopsies. Next slide. So the people in Erlangen chose for a REDCap type database, and they used the structure of the KBC term lists in this database. They used, to be more detailed, the disease concepts, and it really makes, like you see in the left, some sort of click. So they really could click the codes, and if you click something on, the codes behind appear, and this is very easy for the nephropathologist. Only has to click. The codes are in the background, and the extra layer, the attribute of the certainty, can be added on. And the experience, according to the nephropathologist in Erlangen, is really good with this system. So yeah, this is some contact information if you want to reach us. This is us. We have a website, though we will, and we have these email addresses currently in use, so you can reach us if you want to collaborate or want to know more.
And in the end, we want to thank all people who have in some way supported us. Of course, the steering group, the advisory board, the societies who have supported or endorsed us, and all the pathologists and nephrologists and other people who have in some way collaborated with us. And last and not least, these 3 national release centers, which help us to find out if there could be a collaboration with Snomed Ct. So thank you.
Thank you.
Thank you very much indeed, Amelie and Sabine. A very interesting presentation, and really interesting to hear your work and how you've sort of developed your thinking over time. There are 1 or 2 questions. One you sort of answered as you were going through, which is how are you funding this, and I think you very clearly stated you're not. So, but you gave some clues as to how you're approaching that and so on. And then there's a comment from Jim Case, the senior terminologist in Snomed Ct, with a thumbs up and saying how great he thinks this is, and that Snomed International is very anxious to work with you. So you obviously have some support at a very senior level, which I think would certainly be the case. And then there's a third question here, which is that there's still a mapping requirement from the user systems to other forms in Snomed, and if you did do that, who would be responsible? I think that is one of the questions always with these systems, is that sort of go it alone type of things always need maintenance and somebody has to pay for it. I think you've kind of answered that question, and in a sense you've come to Snomed International to say, well, is there potential for engagement, collaboration and so on, that might then get wider support from member countries and so on. So I don't know, is there anything else you'd like to add about your mapping requirements?
Yes, of course. It's, for example, the kidney biopsy registries. Also, if I'm talking for the Norwegian registry, this is the old registry. So it has been founded in '88. So we have now 3 versions of a proprietary coding system, which doesn't have the newest doesn't include the newest classifications. So it's somehow outdated, but we still use it. Yeah. Because we also have this backward compatibility. And then the clinicians asked us to introduce the ERA EDTA system. And this is a clinical system which clinicians are used to, and they like it, yeah, because it's easy to handle. And what I did at that time point, I mapped this ERA EDTA system to our proprietary system. It was not perfect, of course, but somehow it still works. Yeah. But what comes now, as if we finish the work with the KBC system, so I have to work again with this. I have to do this mapping exercise again because I want to have this backward compatibility. So this is an issue, of course. But I think in Norway we are lucky to have this. To have the Directorate for e-health, because they are working with our NOPAD system and are doing the mapping exercise there. But of course, it's a big issue. I don't know if you want to comment on this too, Emily.
Yes, it's something that we have pondered over at a lot of times, because we also wanted to, with this project, only map an example, maybe take one proprietary system and show how you can do it, or what can be done. But I guess in the end, it's the responsibility of the registries to implement it, I guess. So yeah, but it's an issue. It definitely is.
Yeah. Well, one I don't know, friend or foe has made a comment in the questions about, rather than mapping, just model all of this in Snomed Ct with maintenance from Snomed Ct, and obviously that would be part of the discussion. I've got a slightly separate question, which is partly brought up seeing you in your laboratory, Amelie. I see you have a microscope there, and that maybe somewhere in the background there'll also be a digital pathology scanner, because I think one of the big opportunities for all of this is obviously image storage using digital pathology, and then the ability to annotate the information with structured data. And has that become part of the discussion in that group that you showed? And do you see a journey using digital path for renal biopsies?
Well, I think it will come. It will be asked more and more in the future, and also so it's possible that the project somewhere develops into that, also facilitating that. But we have not done anything into that field. What we also expect is that maybe some big research consortia or collaborations might be interested in our system. There are, for instance, big American consortia on glomerulonephritis, and according to our information now, they do the opposite. Instead of coding the information, they work with natural language processing often. So this is a different approach. Yeah, it might be that we need to align there somewhere. But this is future, I think, near future possibly.
But it's also a selling argument for structured reporting and code and using coding systems, because people begin to understand that with the possibilities of digital pathology, you cannot reuse it in a good way without, as for example, for machine learning or artificial intelligence, if you don't use coding systems which are interoperable. Yeah. So we use it in our argumentation why it's useful to have such systems, because people become aware of this, of course.
Yeah, so absolutely, and that's obviously where some of where my question was leading to. So I mean, this is great stuff, and I think we've probably run out of time. Jim Case has just commented that image annotation using structured data has been used in other parts of pathology, and I think that's true. And of course, the other big area is in radiological imaging, where machine learning of reporting for X-rays is now pretty common practice, and I think pathology is very, very close behind. But anyway, I think we should draw a close to that. I think there's obviously loads of discussion to have with the two of you in your wider group from Snomed International, and I'm sure that those who are listening in right now, if they haven't already made contact, will be doing so shortly, but I think you're already plugged in. And so it really leaves me to just thank you once more for a great presentation and hope to see you again. So thank you once more again. Bye-bye.
Thank you. Bye-bye.
Bye-bye.
So thank you, Amelie and Sabine, an excellent presentation. We're going to take a short comfort break now, just for 10 minutes, and we'll restart at 10 to the hour with Botesh, who's going to present around the topic of the moment, so around COVID data collection in primary care. So go and have a comfort break, get yourself a coffee, and then we'll start in 10 minutes time. And do remember to come back. Back. Oops. Okay, I'll start again. So hi everyone and welcome back. It's 10 to, according to my clock, according to Snomed time. So we'll restart this session. So I'm going to hand over to Botesh Jani, who's going to talk about COVID data collection in primary care, which in some ways is the topic of the moment. So Botesh, over to you.
Thanks, Ian. Can you see my slides okay?
Yep, we can see them fine.
Excellent. Hello, everyone. I'm Botesh Jani. I'm a clinical senior lecturer at University of Glasgow in the UK, and I'm also a practicing GP or general practitioner, family physician in an area called Bellshill, which is just outside the city of Glasgow in Scotland, UK. So I'll just introduce myself and give a context about where I'm coming from. As I said, I'm a practicing GP in Scotland. My main job is being an academic GP doing research in primary care and family medicine. And I'm also, I've got a full-time post with University of Glasgow doing research. I'm also the co-lead of Primary Care Research Network in Scotland. And my research interests are around primary care depression, cardiovascular disease, and multimorbidity. And I don't have a background in primary care informatics. And I don't have a background in COVID research either, but as with other people, I decided this was a topic which which was very important at that time, and I decided to do some research in the area. So what I am going to talk about is I developed a template or a prototype template for COVID-19 consultations in primary care, and this is a snapshot of the paper which was published in the British Journal of General Practice, BJGP Open, and I used Snomed Ct terms for designing this template. So to give you the context, take you back more than a year ago in February or March 2020, and this was the time of panic when COVID had reached the shores of Europe or about to reach Europe, and it was dominating the headlines, certainly in the UK. And to give you the context of just a brief context of healthcare system in the UK, almost everyone is registered with a GP, and their GP is their first point of contact for any health problem. However, if you have a life-threatening emergency or if you suffer an accident, you go to hospital. But other than that, all the health problems are first and foremost dealt by a GP, and this includes infections as well. So there is a lot of talk about how are GPs going to manage patients with COVID-19. Obviously, calling them to the clinic will just increase the spread of infection. And one of the things which was suggested was doing consultations on the phones and doing telephone triage. Now, GPs in UK are used to doing phone consultations, but they are primarily reserved for things like medication review or for simple problems like that, where you don't need to examine someone. And this was a new territory because GPs were not used to deciding if somebody with infection, how to risk assess them, just by speaking with them on the phone. And a lot of things were suggested on how you could actually speak with someone on the phone. One of the tests which was suggested was Roth's score, where you ask the person to count from 1 to 30 and then kind of measure the time which they've taken, and that gives you an idea how breathless they are. But evidence shows that it's not a very good way. But the point I'm trying to highlight is that we as GPs, we were not sure how we are going to do this and how we're going to conduct COVID-19 related consultations. So the challenges were much was unknown about symptoms and signs of COVID-19. As days and as days progressed, we came to know more about this problem, and we know what are the common and uncommon symptoms now. But at that time, it was a period of uncertainty, and as I said, we didn't know how to risk assess these patients as well. So what we needed is a system of collecting data, and what we thought would be important is if we collect data from the first wave of the pandemic and from COVID-19 consultations, and then use that data, which would help us going forwards in the pandemic. And if you want a standardized, uniform data collection across various centers, a template is an important thing. So our question was, how do we improve standardization and quality in record keeping in COVID-19 consultations? And the answer was to create a COVID-19 consultation template. And that's where we decided to use Snomed Ct. So why Snomed Ct? So as I said, and the health systems across the country were scrambling and trying to put their heads together of how they're going to manage this kind of wave of patients with COVID symptoms. And a lot of different models were suggested at that time, including GP practices setting up separate clinics for COVID, COVID assessment hubs, and then all the patients going to hospitals. And out of all those models, in the end, they decided to go with the COVID assessment hubs. But we thought, what is a common factor across all these three methods of all three different health settings is Snomed Ct is used in recording in electronic health records. And hence we decided to use Snomed Ct for our consultation template. So what we wanted to do was to collate a list of relevant symptoms and assessment items, demographics and lifestyle questionnaire and health conditions and underlying health conditions, which are going to be relevant for COVID-19 assessment in the community. And then we wanted to match these data items with corresponding Snomed Ct clinical terms. And we hope that we would end up with a template. We also thought that a template like this is not going to be easy to implement. So we thought of some ideas of how we can support implementation of a consultation template. So we decided to do a literature search. And this was May 2020, so about 2 to 3 months since the onset of pandemic in Europe, much longer than the onset in China. And this were the figures which the literature search results showed. We had about 963 articles in PubMed and more than 500 preprint articles. We did exclude studies relating to blood tests and imaging because we were only interested in community assessment of COVID-19 and not the hospital-based assessment. And then we looked at what we thought would be important to look at: systematic reviews and preprint systematic reviews and clinical guidelines. So we ended up looking at 21 systematic reviews which were published and 24 which were still in kind of preprint stage. And then we looked at 16 clinical guidelines which were out there. Then this was across UK and internationally. So in total, we had 61 guidelines and papers to look at to extract the information which we wanted to on clinical assessment of COVID-19. So what did we do after deciding our data items and clinical documents? We went to the NHS digital website and found the Snomed Ct code browser, and we used this code browser to find the corresponding Snomed Ct code for a clinical item. And we found this process fairly easy to use. As I said, I'm not from a health informatics background. I certainly found the first talk very interesting, and I thought a lot of clinicians like myself could do with some training in health informatics. But this was without having any background training in this area, and still it's a proof of the quality of this browser that we managed to use it to extract the information which we wanted. So this were our results. We had about 32 symptoms which were current at that time, at the time we published the study, which were associated with COVID-19. Of course, this list has been updated now, and we have got much more symptoms and the evidence showing much more symptoms associated with COVID-19. And we had 20 assessment items, and this included various things about clinical examination. So 20 assessment items were regarded as important. And then some certain demographics and lifestyle features, which we thought were relevant for COVID-19 assessment. And we found 25 underlying health conditions which were found to be a risk factor for adverse outcomes in COVID-19. So we had this kind of information which we thought is going to be relevant to record in a COVID-19 consultation. And then we took this items, data items or clinical items, and then used the Snomed Ct browser to find the corresponding code for these items. We also used the NHS digital website, where there is a browser of converting a Snomed Ct term into the read code, which is another kind of coding system, because certain GP systems were still using the read codes. So we thought it's important to give codes in both terminologies. So this is what we developed, this prototype template, and this is what it kind of looked like. So you would record your symptoms here, depending on, they were classified based on kind of biophysiological systems. And then you record assessment based on the level of breathlessness they had, if they reported having fluid imbalance, and then if possible, depending on the type of the consultation, you record the vitals here. And then you had also the opportunity to what you decide to do with your patient. So this would be after record. General practices in the UK, they all use electronic health record systems, and things like lifestyle, demographics, and underlying health conditions are already coded in their primary care records. So those need not to be coded again, but they can be simply extracted, and so these are the only items you would need to code when you see a patient coming with COVID-19. But designing a template is just one part of it, and implementing is a different ball game. And we thought about what are the barriers and facilitators if we want to kind of roll this out in clinical practice. What will make GPs more likely to use this template, and what will make them less likely to use this template? And we used a theoretical underpinning called normalization process theory, which is designed at looking at it's a kind of implementation science. When you have a complex intervention, how do you normalize this into routine practice? And the theory can help you identify barriers and facilitators. So first of all, it would be important for clinicians to be aware. So remember, I'm talking about the onset of the pandemic, and the awareness about all this was much lower than what it is now, and the rationale of why a template is necessary, because generally speaking, recording a consultation on template often takes longer than doing it on free text, although some people may argue against it, but most people find templates longer to begin, at least to begin with. And once they get used to the template, it gets easier. So we also thought the template has to be user-friendly, otherwise it would simply not, people will not use it. And again, there has to be a buy-in or acceptance of why this was necessary, especially this was the time when all the clinicians were under a lot of stress, and the last thing they wanted to do was to learn a new system or a new way of recording their consultations. So it has to be advertised properly for this to be adopted. And then, as you would probably be aware, for a lot of data items, there are multiple terms or multiple ways of coding it. So there has to be a consensus on what terms has to be included in the templates. And that's what we discussed in the paper, that the terms which we have suggested are just a prototype, and locally or regionally, people, depending on their practices, people may slightly tweak those templates to what suits their local or regional needs. And there has to be a feedback loop once you roll something out, and it's likely that you would experience some problems. There are things which are not working well and need to be corrected. So it has to be an iterative process. So what are the limitations of this study? And the search strategy was quite limited. We didn't have a large team behind this, and it was done with an internal funding, and so people were very much doing it in their own time. So I would say that the search strategy was not extensive. The evidence has evolved. As we all know, there are many more symptoms which we know about COVID-19 which are relevant now, but they were not relevant at that stage. And we included a lot of pre-printed evidence, and I can understand why preprint papers were so popular at that time in the last year, but there is a caveat that they have not undergone the scrutiny of a proper peer review or a journal editor, and that does put a cloud of doubt over the level of evidence you're going to get from them. And it's a proof of concept. It's not a final product. As I said before, it needs work for adopting and operationalization. So, road to recovery. As things stand, if you have COVID-19 related symptoms in the UK, you contact a central helpline and you're directed to a COVID, a kind of a specific COVID assessment hub, which is separate from general practice. So this is not what used to happen before the pandemic. Before the pandemic, if you have any kind of infective symptoms, you call your GP and you would get an appointment to see them. Currently, you end up seeing a doctor in a COVID assessment hub. But I do feel that 12 months or 2 years down the line, COVID assessments will become part of routine care in general practice, because it's not sustainable to run this kind of specialist COVID hubs for a long period of time. And at that time, recording of COVID-19 consultations has to be normalized, and I think a consultation template will help us understand this particular health problem in greater detail. Especially most of the COVID risk scores which are out there have come from data collected in hospital, and there hasn't been much data or research done for COVID-19 assessment in community setting, and that's where I think a template like this can play a huge role. So as I said, there is a research gap out there in terms of COVID-19 assessment in community, and if we get good quality data, we can address this gap, and the template can go a long way in doing that. So thank you to Ian and Charles for inviting me. It was a pleasure to talk about this work, and I'm happy to take questions.
Thanks very much, Bortesh. Very interesting approach and way forward, I think. I'm just I have one question's come through, which is about the longer term plans that you have for monitoring patients, particularly with long COVID, which increasingly seems to be the subject of discussion. And certainly in my own hospital, we have now, specific clinics just for long COVID patients. So there's that question: are there long-term plans in primary care, and also using your template for long COVID patients? And then, do you imagine, or do you see a process for evaluating differences in patient outcomes depending on which vaccine type they've received, whether an mRNA or adenovirus vaccine, or indeed any others that may be invented in between? So I don't know, some open thoughts about that?
Sure. I think those are interesting questions. So if we believe the experts in this field, they think that COVID-19 will become an endemic problem. It will be like any other viral infection in years to come. And while our response to this pandemic is very much central in terms of the rollout of vaccination is quite centralized in the UK, in future they will have to revert back to primary care, where patients with COVID-19 symptoms would be going to their GPs, patients with long COVID would be going to their GPs, and of course the vaccines for COVID-19 will be administered from primary care, just like flu or influenza vaccines are at the moment. So once that happens, I think at that time, again, if we have good ways of recording all this data, then we will be able to do good quality research over all these problems, whether it's long COVID or vaccination side effect. But at the moment, one of the issue is that vaccination has been rolled out centrally, and I'm sure they have got there are a number of studies which are looking at differences between outcomes of different vaccinations.
Thank you. This is a rather specific question. I hope I didn't miss what you said, but have you then implemented your template into EMIS and TTP and Vision 1? And is there data about take up of the use of the template?
Well, it kind of, we didn't implement it into EMIS and Vision and other kind of IT providers, because COVID assessments hubs were run by secondary care, and they often, at least in Scotland, they were using IT software of secondary care for hospitals would use, and so they had their own kind of templates which reflected how you would record these things, and if the patients were to present to A&E or an emergency assessment unit. The downside of that is they don't necessarily use it. They are not necessarily using all the strengths of primary care records in terms of their chronic disease history. So they're asking the patients, do you have these and these health problems? And we all know sometimes patients do not remember all the health problems they have, or their medication record may not be accurate, whereas the primary care records are going to be much more accurate. So the short answer is, again, the COVID assessments are taking place in these hubs, which are using IT software from hospitals, or at least that's the scenario in Scotland.
Yeah. So that's interesting, because I think that is a very different model to then what happened, for example, in London. And I can really only speak actually for East London. But I think one of the phenomena that happened in East London is that patients gave up coming to hospital because they thought that's where they get the infection from, for which I think there's a significant amount of data that that was the case, either in waiting in the ED or perhaps more likely as an inpatient. So although our hospitals were absolutely full to the gunnels with patients with severe pneumonia and many on ITU, there was still considerable access by patients in primary care, and obviously lots of primary care driven assessment, testing, and treatment of patients with less severe disease. So that's an interesting that there was such a different model of work. Very interesting. Yes, and what will your role going forwards be? Are you now the sort of Scottish primary care expert on COVID assessments, or where do you see yourself getting to?
I have plans of doing some research in the field of long COVID. I wouldn't claim to. There are many more people doing excellent research in Scotland on COVID, so I'm not the go-to person. But I have plans of doing some research in the field of long COVID, and kind of use of electronic health records in understanding this further.
And do you think that the now native implementations of Snomed Ct in the primary care systems, is there sufficient knowledge, experience, and practice of using Snomed Ct as opposed to read, for you to have a sort of a system for extracting data and creating? Because I've not used EMIS personally, but I think it is possible to create one's own templates within one's own system, isn't it? One's own local database. And do you think people are doing that?
Yeah, so the picture I showed you of the template was done by one of the co-authors and colleagues of mine who's practicing GP. He said, I know how to do templates on EMIS, and he just spent a few hours doing it, and it was all ready. So I think, as you know, different people have different kind of experience and know-how of working these systems, and if you are used to doing these things, often each practice has got their one go-to person for all the informatics related issues.
Yeah.
If you are used to doing these things, then I don't think it is that difficult to create a template.
Yeah, that's great. I don't see any more questions coming up in the chat bar, Bortesh, and I think we probably really used up all the time we have. So thank you really very much indeed for your really interesting both local experience in Scotland and for your presentation, which is inspiring to us. So thank you very much.
Thanks for having me
to talk, and thank you for a great presentation. Thank you again. Bye-bye.
Okay, so yes, thank you, Bortesh. So we're going to move on with two sections. I'll run one, which is a bit of an update around Snomed International, but with a particular focus around what's clinically interesting, I'll say. And then my colleague Jane Miller will do a bit of a review about some of the clinical groups we currently have, so our clinical reference groups and our clinical project groups. But if I start off, hang on, let me just share my screen. So a quick kind of general update around Snomed. So there's a couple of things going on. One I've already mentioned. So in the back of certainly my mind, because I'm involved both in terms of the fact that the expo this year is based in a European country, and I happen to be the customer relations lead for Europe, but also the fact that we're looking, as we're doing here, running a clinical session as part of the expo and exactly what that will look like. So at the risk of repeating myself, which I do frequently, I'd really encourage you to think about submitting abstracts. The abstracts we've had in the past have always proved very useful, and I've also had a lot of positive feedback from people attending the expo. So, you know, if you have some experience around implementation, if you have things you're working on relating to Snomed, please submit an abstract. So that's my my advertisement for this time in the afternoon. A couple of things have happened this year in terms of Snomed International, particularly around membership. We've had 2 new members join. In Europe, we've had Germany, and in Asia Pacific, the Republic of South Korea. Both of them, in some ways, come to the table in terms of their informatics implementations, if you like, being quite mature in terms of how they use technology within clinical practice. So both of them are certainly welcome as new members, but also I think their experience and some of the work they do going forwards will be invaluable to the wider Snomed community. The one thing I'll mention, because if I don't mention it, someone will bring it up as a question, because they always do. We always get questions about, so what about ICD-11? So we have some internal developments going on at the moment, looking at developing initially content. So we have some content creation based on ICD-11 MMS. The longer term plans will be to develop a Snomed to ICD-11 MMS map. In terms of definitive timescales, we don't have one at the moment, other than to say that we'll make sure that the map is available when ICD-11 MMS goes live, which is in 2022. I suppose the 2 other areas that I'd like to mention are kind of linked in different ways. One is around the community content area. So if you're familiar with Snomed, we publish Snomed as the international release, or Snomed International publishes Snomed Ct as an international release. But we've also developed now the idea of a community content area, which allows content to be made available in Snomed format that doesn't form part of the international release, but can be used alongside of the international release to support practice. So everything in the community content area, first of all, has a Snomed code. Its modeling is aligned with Snomed editorial guidance. So it fits, if you like, if you take content from the community area and add it to the international release. The kind of content which is in there currently, to give you some examples, one, we have the global French translation. So there are a number of languages globally. French is one of the obvious ones, as is German, as is Spanish and Portuguese, that are applicable in multiple countries globally. The community area allows us to, and we have an internal group within Snomed International that's looking at developing and agreeing the editorial guidelines for the global French translation. So the community area gives us a way and a method of publishing that and making it available to any member country that wants to use those translations, or indeed any of our affiliates that want to use translation. Some of the other type of content that's in there. So one of my responsibilities is around genomics, and we did a project towards the end of last year, which looked at developing genomics content, so clinical phenotypes, particularly related to rare diseases. And that content at the moment is in the community content area. And we're encouraging people to go in there and look at the content, review it, and give us feedback on it. There's also content in there related to cancer synoptic reporting. Exactly the same. We're looking at making that content available, but also we're quite open and would welcome feedback on that content. The other development is something called the sub-ontology tool. So one of the questions which I've been asked quite frequently over the years, particularly by clinicians who are developing reference sets or subsets of Snomed content. If you look at Snomed, one of the classic comments that comes back from clinicians is it's too big and it's too complicated. And by developing subsets, you obviously alleviate some of those concerns by making the content you're looking at smaller. But by making it smaller, you also lose some of the context in terms of hierarchies, where things fit, just relating to that subset content. What the sub-ontology tool does is actually allow you to build an ontology based on the same Snomed attributes, the same Snomed relationships, but based around the content which is just in the subset, and give you a view of that. It's particularly useful. So Jane will cover this as one of the groups, but one of the clinical groups that we have currently is focusing their efforts around looking at epilepsy and seizures. And they're aligning it to a classification which is created and published by the International League Against Epilepsy. But their terminology actually has its own ontology basis. So you can take their classification, you can run it through a classifier, and it looks, or it behaves in a similar way to Snomed in terms of the way things inherit throughout the hierarchies. The sub-ontology tool then allows us to just, or allows the group rather, to look at just the epilepsy and seizure content and then make some comparisons between their classification and that content in Snomed. So it's definitely something we'll be looking at, firstly using in the future, but also looking at ways and identifying use cases that we can meet by using the sub-ontology tool. And I'm sure it will. There will be a number of news items about it, which will be publicised on our website going forwards. Two of the things I want to mention, particularly to the clinicians on this call. One of the challenges that our authoring team have is accessing subject matter expertise in particular clinical domains. We have a small but perfectly formed internal authoring team who are all clinicians by background, but they don't cover every single clinical specialty for obvious reasons, I would have thought. So what we're looking at doing is creating a clinical contact database where essentially we have your number or your email address to be accurate. And if we have a particular query, we would like to contact those experts that have expertise in that particular area. The details of that are actually on, if you go back to my initial slides, details of the contact database are actually on the clinical portal, which is on Confluence. If you're interested in that, then please contact either Snomed through info@snomed.org or myself through igr@snomed.org. But we'll be looking at putting out some social media posts where we'll look at actively encouraging people to join that database. The other one to plug during last year, we ran a clinical webinar series, which had a lot of positive feedback. We're looking at continuing to do that in 2021. We have a forthcoming one on May the 12th this year. Details of the clinical webinars, I've posted the URL on the bottom of these slides, and I'll publish these on the Confluence agenda page for this meeting. But we have a session coming up on May the 12th, but we'll be running them on a monthly basis, certainly going through till the October meeting, and more than likely beyond. One of the challenges from my perspective, from a personal perspective, if you like, is actually identifying speakers. If there are either people on this call who would be interested in presenting, or you know people within your own network who would be interested in presenting, I'd be more than happy if you contacted me. But certainly watch our website. The clinical webinars we ran last year, we ran for an hour and a half and had 2 presenters. We're going to slightly change that in 2021. So all the sessions will be an hour in length, and there will be a single presenter for each session going forwards. But certainly watch our website under news and events, and we'll publish details as soon as we have agreed presenters. I'm going to stop there. I'm happy to answer any questions. So I have a quick look in the chat. Okay. So I think I'm going to hand over to you, Jane.
Okay, thank you. Do you want to drive, please?
You want me to drive?
Yes, please.
Hang on. I've got to
Oh,
find...
I thought you were connected up to them.
No. Hang on, mate. Hang on. Wait a minute. I've got to find your. Hang on. I've got to find them. Okay. Hang on. Right. So yes, I'll drive. Oops. Okay. Go.
Thank you very much. Okay, just to recap, my name is Jane Miller. I'm part of the clinical engagement team, but also work with Susie Roy on the collaboration team. So I may be throwing in a bit of collaboration comments on some of these as we go. So Ian's just asked me to talk about our clinical reference groups and clinical project groups. And I noticed that when I looked at the attendees, there are a number of people in the attendees who I've seen in those groups this meeting. And if I'd like to say on behalf of the clinical engagement team and the organisation, how great it's been to see so many of the clinical reference groups and the clinical project groups meeting here this week, and also for you all attending and contributing the way you have. And I would encourage you to stay with us and continue contributing, of course. And I hope it's been insightful for you. So what we thought would be helpful is just to give a quick summary of some of the things which are going on in each of these groups at the moment. Allergies, hypersensitivity and intolerance. At the moment, they are developing an implementation guide related to the use of Snomed Ct terms in relation to allergies. And they're doing that with the group, but they're also talking to the different stakeholder groups, particularly our member countries about this, because quite a number of the member countries are interested in this topic. So it's coming from the clinical end from 2 places almost, both from ourselves and out in our members. So that is work that is going on there. Anesthesia, they met for 2 sessions this week, and they're one of our longest standing groups. And what very, very good is that they also work, several of the members of the anesthesia group also work in HR7 and other standards organizations like ISO. And so that when they're working, they're also picking up work that's going on in those groups, which means that they're picking up things which are appropriate and relevant to Snomed, as well as taking out to those other organisations their experience and the work they're doing with us. They're doing work on assessment scale modelling at the moment. Quite a lot of assessment scales are used in the area of anaesthesia. They have almost got a rolling programme of new content that they're working on, either revising and updating content which is in Snomed Ct, or adding new content as it emerges. And in addition, they've started a major piece of work which is reviewing content in relation to an ISO standard 19223 mechanical ventilation terminology, and to make sure that we've got alignment with that ISO standard, which is obviously a global standard. And certainly for the collaboration team, we spend a lot of our time working with looking at what ISO are doing and making sure generally that anything we're doing takes those standards into account, because those are what impacts people at the local level, at the country level as well. So that's anaesthesia. Dentistry, they've had a couple of lively sessions here. They are a very strong group with global representation. I was delighted to see people from from America right across Europe and across to Malaysia. Unfortunately, dentistry, we didn't get representation a lot from Australia, but because of the time zones. But it's good to see so many people there. They're working. As many of you will know, we produce an odontogram reference set, and that came out of some very good work that was done in Norway, which has gone into the international release and into the international group for review and making sure it represents what's needed internationally. That's been released for a number of years now, but they are doing some updating of that based on implementation experience. And the aim is to produce an updated reference set after the July release of Snomed International, the Snomed Ct International release. So that is based on implementation and usage, which is great. They are also been doing some work for a while on the periodontal content of Snomed, and updated in line with there is an international classification owned by the American Academy of Periodontitis. I get my titis and ontologies mixed up, and also the European Federation of Periodontitis. So they own that, and we're very grateful for them in allowing us to add this content into Snomed with their direction and help, of course. That's part of where Susie and I work, particularly on this collaboration side, to avoid duplication as well, but also make sure that people can use these things together. And they are also, there is another reference set which they developed, which is general dentistry, focused on diagnostics. They are actually reviewing that at the moment and working on adding to that. That is work which won't be in the next update, but they're working towards it. And what's not on this list is that they are continuing to identify how they're going to manage an update to the procedures area of dentistry, which is in Snomed, which does need some work. And they're working through what that might look like, ready for a proposal to Snomed International for a piece of work. Ian heads up at the moment the Genomics and Precision Medicine reference group, which actually had its first meeting, I think this time last year, if I'm correct. Anyway, they are based on, again, the way the group's been going and the topics which have been raised. They're revisiting slightly the scope of the group. the precision medicine discussion paper has been developed with their input, and they are looking at use case requirements. A mental and behavioural group continues to work their way consistently through content in Snomed Ct, and proposing and advising us on content which needs to be revised and is missing. Nursing, we're really delighted that the nursing clinical reference group went very quiet for a while, and we've had a sort of resurgence of it and a relaunch of the group with 2 new chairs, 2 new leads for the group, who we're very grateful to. And the focus of the work, because I mean on the next slide you'll see it, but we have been working with ICN, the International Council of Nurses, to actually incorporate ICNP into Snomed Ct and act as the release mechanism for the product going forward. And so it's integrated into Snomed, but there will also be a reference set released, which for those who are not yet users of Snomed, they can access, get a version of ICNP, electronic version from us as well. And so they have been inputting to that work in a sense of providing feedback and advising us on the appropriateness of content for the global usage. We're encouraging and working with them on implementation and supporting nurses as they move forward into the electronic health record era, how their information, how important it is to be part of the electronic health record, because like all healthcare professionals, they're part of a team, and that usability of their information is so important for others to be able to see it. And I think I would encourage you, there was an excellent presentation at their meeting earlier this week from an implementation in London from a guy called Jason, and I have forgotten his surname, which is very rude. Jason
Pot.
Thank you very much. Thank you very much. But that's why we're a team. And I would encourage you to go and listen to it. I spoke to somebody earlier today who'd listened to it, and they actually come from the dietetics and nutrition world, and they said how it applied to them just as much as it does to nursing. So I'd encourage you to go and listen to what he is using Snomed data at a number of different levels, and being able to then achieve changes to services as well as practice, which is really good stuff to hear. So that's ongoing there with the nursing clinical reference group. Next slide, please, Ian. Diabetes. Now, I just want to talk a little bit about a number of the project groups. Project groups are task and finish, and a number of them are closed because we've got people who've agreed to do the work and we're getting it done and things. Now, the diabetes project group, we've got on here, it's currently on hold, but I've had an update from Paul Amos, who chairs that group. And the reason why it's been on hold is because a lot of the, and this is applied to quite a lot of our clinical reference groups, as you can imagine, particularly the anaesthetists, because of the pandemic. But they are just about to start work again. Now, their focus is on actually reviewing current content related to the different aspects of diabetes across the spectrum in Snomed and updating it, plus as they go, identifying the gaps. So what he has said to me, because he can't be on the call at the moment, is that they would welcome hearing from new clinical people in whichever specialty they are in. And they may not be doctors, they may be nurses, they may be podiatrists, particularly, I mean, it doesn't really matter which discipline they're from, and renal physicians and others, those who have link with diabetic patients. So if you want to take part in this work, please reach out to us, and we can connect you up with Paul, and he can give you an update on where they are. And he knows when they're going to be addressing each particular area. Ian has already mentioned epilepsy from the view of this wonderful ontology tool, which we now have at our disposal. Rory is making us hold back a little bit. He wants it to make. We want to be making sure that it can stand the testing and people like me who break things. But we're all very excited at what this means certainly for clinical users, and those are the key people I've spoken to so far. I would encourage you to, when the demonstrations are available, when you get the opportunities, take a look at it. It's not complete and things, but it's a great tool for showing the ontology in relation to your particular areas of clinical expertise and things that you might want to do. And I'll talk about it in a minute about nursing, but so anyway, that's the epilepsy. They're doing a revision of the content related to epilepsy and seizures, and that alignment with the International League Against Epilepsy classification. So again, we are making sure we do alignment rather than reinventing the wheel and having SNOMED versus. It's much more about collaborating and working together. So ICNP 2019, I've already mentioned that. We had a project group, which is actually now finished. And they actually reviewed we already had quite a lot of ICNP content in SNOMED, but what they were doing was reviewing the remaining content which was missing to ensure that we got all the content in. Kathy Richardson, one of our authors, is at the moment beavering away to get all that content into SNOMED in time for a first release of the ICNP product, the reference set, in the autumn, in September. So it's very, very exciting. And that will be managed then through a group at ICN. ICN can maintain governance over that product, and they have an editorial group at that end who make decisions about what content is in ICNP and what content is not in ICNP. Similarly, we've been working with the American Nutrition AND, the American Nutrition Association, and they have NCPT, Nutrition Care Process Terminology, and that is going into SNOMED as we speak. They are working with a clinical author and identifying all the content which needs to be added, and that is because there's global usage of NCPT. It's not just used in the US, but right across the globe. And so they are working through that, and we expect to have the content in within about 2 years, because it's based on their availability and their timelines, but it's being released as we go. So and I've spoken to them about the wonderful ontology tool, and they've seen the nursing stuff demonstrated. No, dentistry, I think they saw it demonstrated, and they certainly think it will help with them as they come out of the other end and the content is added, to have a look at that. And finally, we have Sex and Gender project group, which that's focusing on reviewing and updating the Snomed Ct content in relation to representation of sex and gender in Snomed Ct from a clinical perspective. And there's work being done by other standards organizations in this area, particularly HL7. And I think if I remember rightly, it's becoming a topic at ISO. So we will making sure as we go by linking, having on the project group, somebody from the HL7 vocab group, and we will link across and watch what ISO do as well to make sure that we've got some interoperability there. Plus, we do have non-clinical folks. We've got members of the public who are impacted by the decisions which are made on that group, which is great. And I think that is all I want to say, except to publicize the fact that we are in talks at the moment, because we don't, unless it's a project group that the content team feel we need to have, which happened with diabetes and sex and gender, we don't put these things to, we don't put project groups together unless unless the organization is ready to do the work. From a clinical reference group, again, it needs to come from the world out there. And we've been approached by a couple of groups who are interested in putting together a neurology group and also an ophthalmology group. So we are looking at that at the moment. But the big thing that we are also looking towards, we do have a pathology group, but it has been a little bit quiet for a while. So we are talking, we are working through how we can do a restart on that group, given that the demand for pathology information is key. And obviously COVID has thrown it up yet again. And we had that excellent presentation earlier on. I think we're timely again. It's never gone away. There's always been, we've always had the advice of experts behind us, but actually clinical folks, you know, they have day jobs as well. So we need to help and support that getting going again. Thank you. I think that's all.
Okay, so yes, it is. So thank you, Jane. And I'm gonna stop my share there, and I'm gonna hand over to Charles to make some concluding remarks. So Charles, over to you.
Thank you very much indeed, Ian. So I won't take an enormous amount of your time, but if I could just hold on to you for 2 or 3 minutes. Can I start by first thanking Alison, Fleur and Kelly in putting together this spring conference. They always do it fantastically well, whether we're meeting face-to-face or using these remote connecting devices. And this one has worked brilliantly and flawlessly, I think. So thank you very much to those three who always bring it together. Secondly, can I thank Ian and Jane, my 2 colleagues, in creating this afternoon's session, which I think has worked again beautifully. We've had some amazing presentations and a great conversation on the work that Snomed International does at a clinical level. And thanks to the hard work that Ian and Jane put into finding people, chatting them up and persuading them to talk, always a test of one's virtue. So thank you again. And then I suppose I'd like just to talk for a second or two about why does Snomed matter? And that was, of course, a strong theme in what Tejal talked to us about this afternoon. And I think underlying all of this is that each of us is a citizen in our countries and a citizen of the world. And we become patients over time. We lose our health and we become sick. And this year has been an extraordinary example of the risk that a pandemic brings to everybody, regardless of age, regardless of gender, regardless of all, you know, all of the sort of physical determinants of health. And we're very aware that the social determinants of health actually have had a horrific influence on one's personal risk for developing COVID. So if you're poor and uneducated and living in very compressed housing and so on, your chances of getting sick with COVID were much higher than someone like myself living in my little bunker in the middle of Dorsetshire. And I think Snomed, as part of the family of digital tools that we can use for health delivery, make a huge difference to our ability to deliver health to people successfully. Snomed provides a language of health, which we can use in many, many different ways, and which, if you've ever heard me talk about, I sort of break down into the components of the point of care access to data, the ability to message information, and something which I feel incredibly strongly about now, which is you can use that data to message directly to patients and to create health records which they have themselves and which they can use to maintain and look after their own health using systems that they have in their hand. And then there are extraordinary benefits from Snomed for new discovery and research. And we've seen that illustrated this year amazingly by a new infection appearing far away from us in China at the beginning of last year, with WHO publishing the sequence data on COVID-19 on January 20th, I think, of last year. And now, you know, a whole series of studies which have been made better by using Snomed, research studies across the globe, and the development of vaccines, which again are being recorded often using Snomed terms and so on, at least in this country, but I believe more broadly abroad, and making a difference to people's lives, even if in a very difficult circumstance. So let me finish essentially by thanking our three speakers who I think talked about all of those themes. Tejal in speaking about the need to teach and learn and understand how Snomed works, and the fantastic work that she's been doing up in Newcastle in making that possible and creating a set of educational tools which I think are exemplary and which we should all copy and find ways of delivering to more people. A great plea, I think, from a set of renal pathologists wishing to collaborate in creating new knowledge by developing their bespoke system for coding renal biopsies. And there is absolutely no doubt in my mind that there are opportunities for that collaboration to blossom, and that there is an amazing importance in getting the histological diagnosis of renal disease correct, because so many of these conditions end up with patients severely ill with chronic renal failure on dialysis and requiring kidney transplant, and anything that can reduce that flow of patients to end-stage disease by knowing more about the condition and using both you know, terminology and digital pathology to learn more about renal disease would make an enormous difference to people's lives. And then finally, a great presentation from Botesh on the possibilities there are essentially for local data collection using the tools that we already all have in our health economies, and I think that's a great example of local innovation without much expenditure. Again, using terminology as the resource. So thank you to our our four speakers actually. Both Sabine and Amelie, thank you as a pair, and I really enjoyed everything that was presented. And then finally, a thank you to the 100 or so people who attended this afternoon, stayed with us and listened thoughtfully through all of the presentations and our discussions. So thank you so much for coming. and I hope we see you in October at the Snomed Expo, either physically or virtually, however it happens. Thank you very much indeed. Bye-bye.